let's mention briefly Kluver-Bucy. So this happens when you have bilateral amygdala lesions. So that's even further anterior of the hippocampi. And so you have patients, and I've actually never seen a patient with this, but they have hypersexuality, emotional placidity, and they have a couple things called a couple of other features, hyperorality. So they'll put things in their mouth to figure out what they are, like babies. And they'll also have a visual agnosia, which we talked about earlier on. So this can happen if you have a temporal lobe lesion as well. One of the things that I always get asked is how you can tell the difference between these folks and our orbital frontal syndrome. And we talked about this a little bit earlier. And I think the key is that, at least my understanding is that for your Kluver-Bucy patients, they're more placid. They're a little more, I guess, low key compared to your orbital frontal patients who sort of always the life of the party, but in a bad sort of way. All right, so let's keep going. So let's talk about a couple of amnesias. So let's talk about hippocampal amnesias. We spent a lot of time talking about that. I think the big emphasis that I want to make here is we talked about bilateral hippocampal damage. So the scenarios where I think about that clinically are anoxia. So if someone requires CPR, they code, like we like to call it. They have a herpes simplex virus, so that has a tendency to hit the temporal lobe, so you can see that. And there's also something called the limbic encephalitis that can happen in certain autoimmune diseases that you might see when you get into the clinics, and that can all lead to this hippocampal amnesia that we've been talking about as well. The other thing that I think is worth mentioning here, or at least emphasizing, is something called a transient global amnesia, and it's a little bit of a curiosity when you first read about it. But I've weirdly seen like 3 or 4 patients with this. And so what happens is you have this sudden anterograde, so inability to form new memories for a few hours. So basically your patient comes into the ER and their family members bring them in and say, yeah, they were doing fine. And we were just walking through Walmart or whatever. And all of a sudden they went, where am I? Why am I here? What have we been doing for the last few hours? And we do this whole workup. And we try to figure out what's going on. We're going to get an MRI of the brain, do a whole bunch of other stuff, maybe an EEG to see if there's some weird seizure going on, and everything is normal. And after a few hours, this gets better on its own and never to come back. So it's important to recognize that, because weirdly it can pop up. If you're not aware of this diagnosis, it can be very, very confusing.
When I was looking at this slide earlier, I thought of there's a famous patient that the students may remember from like introductory psychology courses. His name was HM. Well, that's his initials were HM. But HM had bilateral removal of the medial temporal cortex because of seizure activity. And he's a classic patient for hippocampal amnesia. And it kind of shows you the division of labor as well. So what HM could not do was retain any information for more than about 5 minutes, any new information. His intellectual functions were relatively spared, so his IQ was not appreciably damaged by that. And he had some damage to remote memory, but he could recall most of the autobiographical events of his life, and that system was spared. So it kind of shows you what the medial temporal areas, the hippocampus does, its important role in laying down memory traces, and it actually spares the recall of a lot of learned information over time. And the frontal lobes are much more involved in retrieving that kind of information. So it's a good example of the difference between hippocampal amnesia and frontally based amnesias.
Yeah, as I understand it, he had that temporal lobectomy, bilateral temporal lobectomy. That was a surgery done to him, I think, in 1966, something like that. But after that, every day for 20 or 30 years, however long he lived, he kept thinking it was 1966 because of what you were saying. It was basically Groundhog Day for the poor guy.
Right. And patients with Alzheimer's disease, when they have severe memory impairment, are very much like that.
Yeah.
They just don't remember things from 5 minutes, from one 5-minute period to the next 5-minute period.
Yeah. All right, let's talk about Korsakoff's amnesia. So this is a big testable one. So there's a few features to think about here. So you'll have patients who have, basically, think about someone who has a history of a lot of alcohol abuse. So they'll have a chronic thiamine or B1 deficiency there. And you'll get this lesion that you'll often see in the mammillary bodies here as part of that PAPE circuit. So we talked about the ability to form memories and this structure being a part of that. So that comes from that. You can also see some other features that include ataxia, nystagmus, and long-term mostly because of the effects of the alcohol of peripheral neuropathy. But for your purposes, pay attention to the memory issues, especially with the confabulation, the ataxia, and then the nystagmus. So nystagmus is when you ask someone to gaze either laterally or one direction or the other, their eyes sort of bounce because they can't stay or focus on a specific spot.
Yeah, that's a great characterization of the neurological presentation of Korsakoff amnesia. One of the things I'll want to point out to students is that we notice in Korsakoff's amnesia that these patients often confabulate. And what confabulation means in an evaluation is that you ask them some kind of question and they provide you with an answer that's not necessarily related to reality at all. So if you're testing their memory, for example, and you tell them a story and you say, oh, I want you to tell me everything that you remember from the story that I just told you. These patients will launch into some fanciful story that has no relationship to what you told them at all, and they won't even recognize that they did it, right? They're different from the patients with like medial temporal amnesia alone because those patients don't tend to confabulate. So what would be the difference there? Well, in these Korsakoff patients, they not only have damage to some components of PAPE circuit, like the mammillary bodies, but they also have damage to the dorsomedial nucleus of the thalamus. The dorsomedial nucleus of the thalamus pretty much defines in its projections the prefrontal cortex. So one effect of that lesion could be a deafferentiation of the prefrontal cortex. So they have not only damage to PAPE circuit, but they also have an undercutting of the frontal lobes. And this could be one reason why you see confabulation, because confabulation is a little more common in patients that have frontal lobe deficits or impairment.
Yeah, confabulation, I've seen that a couple of times. These patients, like you said, they're super confident about the answers that they give you, even though they're completely wrong.
Yeah.
We were talking about Anton syndrome earlier on, and when you see these patients, for someone like me, I might ask them, am I wearing glasses? And they'll be like, yeah, there are these and they'll give you very explicit details about the glasses that you're not wearing, and so on and so forth. So it's really interesting when you do see that.